we have already discussed the wound management part. Now we are going to discuss about lymphedema, wound management, lymphedema, ostomy care, and subcutaneous infusion. So I think I can switch off my video so that my audio is clear to everyone. Let me share my screen. I hope my screen is visible to everyone.
Yes.
So this is a patient scenario. Miss is 50 years, was diagnosed with the carcinoma breast, left with the lymph node metastasis about 1.5 years ago. So she underwent modified radical mastectomy with accelerated section followed by chemotherapy and radiation. She has been noticing that her left upper limb is progressively getting swollen for the past 3 months. She feels it's heavy and experiences pins and needle sensation along the whole limb. So my question is, what is the probable diagnosis?
Lymphedema.
Lymphedema. Any other opinions?
It could be DVT.
Why you are telling this is DVT?
It could possibly upper limb thrombosis could also be seen with breast cancer patients.
So, okay, any other opinions?
Because modified a radical mastectomy with accident dissection, I told it was lymphedema.
Yeah, so that's correct. Thank you. We have only limited time, so I think I can move on to that. This is lymphedema. So this is this patient is diagnosed with carcinoma breast and already mastectomy, total mastectomy was done and followed by chemotherapy and radiation was done. So these are the 3 possible causes for developing lymphedema for this patient. So one is total mastectomy, and the second one is chemotherapy, and the third one is radiation. So we are going to discuss about lymphedema. So in our lymphatic system, we all know that throughout the lymphatic system, lymphatic fluids is circulating. So what is lymph? Lymph is a tissue fluid or an interstitial fluid is collected through the lymphatic capillaries, then enters into the lymphatic vessels to lymph nodes. It contains, then finally it goes to the circulatory system. So lymphatic system is also a part of a circulatory system. It contains protein, lipids, and water. So the major functions of lymphatic systems are reabsorb excess interstitial fluid, transport dietary lipids, and the third one is lymphocyte development and the immune response. If there is anything happening into the lymphatic system, this part, so these all things might be affecting. So especially the third things, the lymphocyte development and the immune response. This is the most important area. If there is any problem developing on area, so that area is prone to develop infection. So here is the interstitial. So we need to understand where is the lymphatic fluids verging. So here there is a connection between the arterial capillaries and the venous capillaries. When the arterial capillaries and the venous capillaries are communicating together, what happens? So there is a leaking out of fluid-like substance into the interstitial space. That fluid is called lymph. That fluid is absorbed with the help of a lymphatic capillaries. That is the greenish color. So you can see that. So you have to understand that wherever the arterial capillaries and the venous capillaries are communicating together, there is a chance of leaking out of fluid into the interstitial space. That's called lymphatic fluids. This fluid is absorbed with the help of a lymphatic capillaries. So the lymphatic capillaries, if you look into the lymphatic capillaries, it has a blind end and single layer of overlapping endothelial cells. So that wherever the fluid, the lymphatic fluids origin, that fluid will be collected with the help of a lymphatic capillaries, and then more permeable than that of blood capillaries. So this is more permeable because of that these lymphatic capillaries are easily absorb the fluid from the lymphatic capillaries and the interstitial space. And then after the lymphatic, when they absorb the lymphatic fluid from the lymphatic capillaries, it goes to the lymphatic vessels, and finally it goes to the lymph nodes for filtering out the harmful substance. So in our body, so it's around 600 to 700 lymph nodes are there. So along with the pathways of the lymphatic vessels, lymph vessels, it will be located. So it's around the length, it's around 6 to 25 millimeters, so typically found in clusters. So this the main function is receive lymph from the many body regions and then filtering out the harmful substance. So let's see how the lymphatic system works. Here, the lymphatic system, we already discussed what is lymph. That is, lymphatic system circulates the protein-rich fluid throughout the body. It might contains bacteria, virus, and waste products. So when the lymphatic capillaries are absorbed the fluid from the interstitial space, and then it goes to the lymphatic vessels, and then it enters into the lymph node. So what is the function of lymph node? So the lymph node will be filtering out the harmful substance from the lymphatic fluid. If you just imagine if there is no lymph node into one area, so what happening that area? So if there is any infection develop, there is no the lymph node and the lymphocyte not there for that resisting the infection. So that area might have developed infections frequently. So this is how the lymphatic system works. From the lymphatic interstitial space, the lymphatic capillaries will be absorbing the fluid, and then it goes to the lymphatic vessels, and then it enters the lymph node for filtering out harmful substance, and then again it goes to the lymphatic vessels, and then again it in between there will be a lymph node there. If there is a lymph node there, definitely the fluid will go enters in for filtering out harmful substance, and then it goes to lymphatic trunk. Finally, through the collecting duct and supply, that will that fluid is enters into the subclavian vein. So let's see what is lymphedema. So now you have an idea about the lymphatic system, that what are the functions and what is the pathophysiology, that all things you understand that. Now we are going to learn about lymphedema. So lymphedema is a pathological accumulation of protein-rich lymphatic fluid into the interstitial space due to an imbalance between the interstitial fluid production and transport. So if there is an imbalance between the interstitial fluid production and transport, so the production will be there all the time, because there will be the arterial and venous capillaries will be communicating all the time. So if there is a that function that is happening in the interstitial space, that time definitely the fluid production will be there. The lymphatic fluid production will be there, but the transportation will be affecting. So if there is any problems developing into these things, these production or transport, so that there is a chance of pathological accumulation of protein-rich fluid in the interstitial space. So that's called lymphedema. So
Shiba?
sir,
got muted. Sir.
yes.
Okay.
Okay. So sorry. According to the International Society of Lymphology, so the lymphedema is classified into two: primary and secondary. Primary is related to congenital lymphatic dysplasia. From the birth itself, if there is any malformation there in the lymphatic system, the patient, that baby can develop lymphedema. And secondary, again divided into two, is there is any anatomical obliteration of the lymphatic system. Again divided into, the secondary is divided into two, malignant and non-malignant. So from this slide, you have to understand that non-malignant persons can also develop lymphedema. And coming to the diagnosis part, you have to take a proper history, because this is very, very important. in palliative care, we are not going to do major infestations and all. So we usually take a proper history based on from the patient's history. We can understand that whether the patient is having lymphedema or not. And you have to take a proper history, whether there is an unknown cause or disease related or trauma related, and also treatment related. And after that, you can do the clinical examination. So there are 3 stages of lymphedema. The first one is pitting edema stage. So it looks like a orange peel skin. So when you apply pressure on that area, your finger pressure is your point. Your pressure is you can able to see that area. That is the pitting edema stage. The stage 2 is the tissues have become fibrotic. Little bit hard will be there. Hardness will be there if you not giving much attention on the stage 1. So it definitely the tissues will be fibrotic and hardened. And third is the tissue considerably hard and cartilage formation will be there, and creases formation also there in the third stage. So the stemmer sign, this is the only one sign which we have seen in lymphedema patients. For a healthy persons, we can able to fold the skin of the second of the proximal part. But if the patient is having lymphedema, you cannot lift out the skin or the fold of the second toe. So that is the stemmer sign. For the upper limb, inability to pick up the fold of skin or the proximal phalanx of the second toe, or for the lower legs, you cannot lift up the proximal phalanx of the second toe. For the upper limbs, you cannot lift out the skin on the middle finger of that part. You cannot. So that is the positive sign of lymphedema. This is the only sign which we have seen in lymphedema patient, stemmer sign. So these are the other diagnostic methodologies. So you just see these things, soft tissue imaging and lymph vessel imaging and bioimpedance spectroscopy. These all things, if you do these all things, you can able to determine the extra fluid volume. You can detect the abnormalities, and also you can measure the interstitial fluid volume. So this is applicable more in the primary classification. If there is any congenital abnormalities there, then you can do these all things and find out what is the problem. But if in palliative care, better you can take a proper history and do the physical examination. Then you can able to diagnose lymphedema, whether the edema is lymphedema or other edema. So problems, we all know that if one limb is huge and one limb is normal, the huge limb, the lymphedema hand will be painful and discomfort because of the fluid volume. Tightness will be there, heaviness, they can feel heaviness, fatigue, numbness, impaired mobility. They are not able to move their limbs independently, loss of functions. And coming to the psychosocial problems, body image, it will be affecting the patient a lot because altered body image and loss of independence, sometimes loss of change or employment, difficulty in wearing clothes and shoes, and the patient will be anxious about this edema. And sometimes when the patient's getting this kind of edema, they might be thinking like the disease is spreading to their arms too. So these all things, they affecting the patient a lot, because whenever you have seen a lymphedema patients, so where you just listen to their problems and just to make them understand that what is lymphedema. So that is the important part you have to do for the patient, because otherwise they might be thinking that the disease is spreading to the limbs too. So coming to the management part, there are 4 principles of management: skin care, massage, compression, bandaging, and exercise. These are the 3 principles of management. And intermittent pneumatic compression pump is also you can use, but in case of stage 1 lymphedema period, you can use intermittent pneumatic compression pump. Otherwise, it won't help. So if you do the management, you have to take a measurement. So that part we have a video. We are planning to show a video that all things you will understand from the video. After that, we will discuss. And coming to the skincare. So I already said there are 4 principles of management of lymphedema: skincare, the massage, the third one is bandaging, and fourth one is exercise. Skincare is also important. You have to educate the patient about the skincare. And massage, again divided into 2, manual lymphatic drainage and the simple lymphatic drainage. So manual lymphatic drainage is done by a trained professional. Okay, so simple lymphatic drainage, you can educate the caregiver and patient. So how to do this simple lymphatic drainage. So the major difference between the manual lymphatic drainage and the simple lymphatic drainage is the manual, for the manual lymphatic drainage, the trained persons can touch the lymphedema part. But in the simple lymphatic drainage, the patient should not touch the lymphedema area. Okay, the affected area, the patient or caregivers should not touch, because we all know that the fluid is accumulated in the interstitial space. The simple gentle pressure is enough to move fluid from one space to the next area. But if you train the caregivers, or you can teach the patient, they don't know how much pressure is up for moving the fluid from one space to another. So they will give more pressure. So what happens if they give more pressure? The blood circulation will increase, and for that leads to the fluid accumulation huge. So the small gentle pressure is enough. So the manual lymphatic drainage is done by a trained professional. Whereas the simple lymphatic drainage is done by a patient and caregiver. You can train the caregivers, and when they are in the hospital, you can do the manual lymphatic drainage. When they go home, they are planning to go home, you have to teach the caregivers and patient how to do the simple lymphatic drainage. So after that massaging, you can do the bandaging. So initially you can give a spiral bandage that is 50% overlap. So after that, you can train the caregivers for how to apply bandages, and then after 1 week they can come for review. That means follow. So if you do when they come for a follow up, you can just reassess whether they can able to tolerate the spiral bandage or not. So if they are able to tolerate the spiral bandage, then you can think about the multi-layer bandage, that is figure of 8. That means more pressure you can give, you're going to give a more pressure on that area. Our aim is to push the fluid from the congested area to the non-congested area. Okay, so if they are able to tolerate, better you can move on to the figure of 8, that is multi-layer bandage. So after that, for the upper limbs and lower limbs, you can do the bandaging. The bandages are same. For the first initial period, you can do the spiral bandaging, and then you can move on to the figure of 8. And then the last one is exercise and elevation. So after bandaging, you can teach the patient for a exercise, small exercise, one for the fingers, and one for the wrist, one for their elbows, and one for shoulders. So if they are not able to do it, you can train the caregivers for giving a small exercise for that affected part. So we can watch a video on this, and then the video is clear to everyone. Anybody have any doubts? So here, what you have to understand is we are going to push the fluid from that congested area to the non-congested area. So for that, you have to ask the patient to take a deep diaphragmatic breathing, so that all internal lymph nodes will be stimulated and they are get ready to receive the extra fluid. And then you can stimulate the superficial lymph nodes. And also you can stimulate the opposite side of the axilla, unaffected axilla, and then make a pathway, like clear the chest and clear the groin area. So we are going to just keep it in mind, you are going to push the fluid from the congested area, the edematous area, to the non-edematous part. So we have to make a pathway, and then you can try to push the fluid from the edematous area to the non-edematous area, and you have to clear the proximal part first and then go to the distal part. Okay, always you have to give a gentle pressure for moving the fluid from one place to another. If you give more pressure on that area, what happens? Again, the blood circulation will increase, and that leads to more fluid accumulation, formation will be there. Because the arterial and venous capillaries are communicating together, and again, more fluid leakage will be there. So simple, the gentle pressure is enough for moving a fluid from the one area to the another area and from the interstitial space. So after that also you have to ask the patient to take a deep breathing exercise. Okay. So after this massage, then you can apply bandages. So we are going to show that video again, and then the bandaging part now, and then we will discuss. Thank you. Any doubts? So,
Madam, this bandaging should be kept continuously for 1 week without removing?
Because when the edema comes down, the crab bandage will lose. So you have to train the caregivers how to apply bandages. So
you don't have to remove it in the night and keep it and then reapply.
No need to remove it in the night during the night time. But because when the edema comes down, the bandage will loosen. But if you give a elastic type stockings, not a crepe, stockings.
Okay.
So that you have to remove at night, because when the edema comes down, that things, the more stockings will give a more pressure on the tissues. The tissues may not get adequate blood supply, so that so that's why we usually said if they are using stockings, they can remove at night.
Thank you.
For upper limb and lower limb, both is the same technique?
Same technique, ma'am. But the manual lymphatic drainage is little bit different.
Okay, for lower limb.
For lower limbs.
Okay.
So there are some contraindications for manual lymphatic drainage. If the patient is having acute cellulitis, then you should not do any active management. You have to control the cellulitis, manage the cellulitis, and then you can move on to then you can manage the lymphedema. If the patient is having severe renal failure there, then always you have to keep it in mind. We are going to push the extra fluid, no? So if there is a problem there in the renal system, the kidney, so there is a chance of fluid overload, no? The patients will be affecting a lot. So unstable hypertension, severe cardiac insufficiency, hepatic cirrhosis with abdominal, the ascites, superior vena cava obstruction. So these are the contraindications. And there are two complications of lymphedema. One is cellulitis. So if the patient is having cellulitis, you can give some antibiotics for that and control cellulitis, and then you can do the active management. And the second one is lymphoria. Lymphoria is oozing out of extra fluid from the lymphedema site. So here that application of crepe bandages is not you can do crepe bandages because here the lot of fluid, the oozing out of fluid from the lymphedema site, no? If you apply crepe bandages, so that all extra fluid will drain out. So you can give crepe bandage. This here application of crepe bandage is not contraindicated, but in case of cellulitis, you should not give any active management. You have to control the manage the cellulitis part with the antibiotics. Here you can give a crepe apply band non like crepe bandages, and do one thing, you can give a dressing pad into the lymphoria site, and then you can do the crepe bandage. So these are the two important complications in lymphedema. So I think we can stop here.
My question
any
is
other-
one. My question
Yes.
is one for lower limb. Bandaging is better or stockings is better? Which one?
If the edema is unilateral, you can go for stockings. But if the edema is not an unilateral, then you can go with crepe bandages.
For unilateral, yes, correct. Stockings, we can do it.
Yes.
Okay, fine. This is I'm asking, yeah, because I have a in-house, so that's why I'm asking that.
Okay, ma'am. Okay.
Thank you.
Any
Okay.
medicine given for lymphoria? Any medicines?
No, ma'am.
Okay.
So I think
All of you better learn how to adapt the thread bandage, which might be asked for a skill. That's what Sri Priya tells me.
so you have to understand that the 4 principles of management of lymphedema. What are the instructions you have to given to the patient on skin care, and the difference between manual lymphatic drainage and the simple lymphatic drainage, and the complications, and also as sir said, how to wear crepe bandages, how to apply crepe bandages. So I think
Tell us about simple lymphatic drainage.
so if time permits, I'll show a video on that. So now I can move on to the ostomy part. So there are coming to the ostomy care, there are 2 types of ostomies you have seen: input ostomies and output ostomies. So input ostomy, tracheostomy, gastrostomy, feeding jejunostomy. Output ostomies are colostomy, urostomy, and ileostomy. So here is the patient scenario. Can anyone please read it out?
Mr. Raman is a okay. Go ahead. Go ahead.
Hello, can I go ahead?
Mr. Raman
Yes.
is a
Yes.
35-year-old gentleman. He was diagnosed to have a carcinoma 2 months ago. He underwent proctocolectomy and ileostomy followed by chemotherapy. He has now come to the OP accompanied by his wife with skin excoriation around the ostomy site. He looks tired, agitated with poor skin turgor. His wife says after the surgery he is angry and upset. Why he is angry and upset?
Okay. So what could be the possible reason here for developing skin excoriation?
Maybe localized to infection.
Okay. Any other answers?
Maybe the bag is not applied properly.
Okay. Thank you.
The adhesive material might be allergic to the skin.
Okay. Any other answers?
The contents of the colon, it may be irritative to the surrounding skin.
Okay, very good. So here you have to understand that this patient is having ileostomy. So we all know that the parts of small intestine, this is a part of small intestine. So, and also we know what are the major functions of small intestine. So here the major absorption, the nutrients absorption is happening into the small intestine, and after that fecal matter goes enters into the large intestine for absorbing that fluid and salt. No, so here if there is any problem developing into the small intestine, so these all functions will be affecting. Here this patient is having ileostomy, and output of from the ileostomy, it might be 500 to 1300 ml. So because of this, the fluid absorption is not happening well, no? And the second thing is that leads to electrolyte imbalance can happen. And the third one is the higher concentration of digestive enzymes that can irritate the skin and develop skin discoloration. So this is the possible cause for this patient to developing skin discoloration and excessive water loss. So here the absorption is not happening well because through the ileostomy the fecal matters will coming out. So because of that, the patients might have developed dehydration and developing renal stones. So these are the problems can happen, and if the patient is having ileostomy, because the patient is upset also, angry and upset. Because, so pre-operative counseling was done, but he couldn't expect these all things. He agreed with that, and after that he couldn't expect because lot of physical problems like skin discoloration. He was not able to fix the bag properly because of the skin discoloration. So these all things will be affecting the patient a lot, and dehydration because of that, and electrolyte imbalance also happens because of that. The patient is having tiredness and all. So coming to the colostomy, here we all know that what is stoma. Stoma is an opening that connects to the body cavity to the outlet to the environment. So here is the stoma. If the patient is having stoma, you can wear a colostomy bag on the top of the stoma, and we know when the bowel move, whenever our bowel is moved, the fecal matters will come out. No, so there is no sphincter control. So you can collect the fecal matter with the help of a colostomy bag. So this is very, very difficult because even if you do the pre-operative counseling also, after that they initially they will agree, but after that they will not be able to tolerate these kind of things, because when they the foul smell will be there. That will be affecting the patient family. So these all things will be affecting the patient emotionally because of the my problems. Others will be affecting. So these kind of things will be there. And sites, we know if the patient is having any problem with the small intestine, we usually do the ileostomy. Like sometimes it's the ascending part area developing a tumor. That time also we usually do ileostomy. And we know there are 4 parts of large intestine: ascending colon, transverse colon, descending colon, and sigmoid colon. So this is very, very important because the nature of output will be different, and the problems are different, and the management is also different. So depends upon the patient's ostomies, that areas, the colostomy, the problems and the content all will be different. The management is also different. So coming to the colostomy, colostomy is an opening created to the body to allow the renal. We know that whenever our bowel is moved, the fecal matter is coming out. That will be collecting with the help of a colostomy bag. Here, as I already mentioned, there are four parts of large intestine: ascending colon. So here, when the fecal matter is coming from the ileum, the fecal matter it look like the liquid and acidic, and unpredictable output will be there. So you have to keep it in mind. The ascending, if a patient is having ascending colostomy, the output will be the liquid and acidic, and unpredictable output will be there. And coming to the transverse colostomy, the liquid, the fecal matter will be liquid to semi-formed, but here also unpredictable output. And coming to the descending colostomy, the semi-formed to completely formed stool will be there. Output mostly we can predict. And coming to the sigmoid colostomy, stool completely formed, we can able to predict. So after food intake, so 6 to 8 hours, they can wait for that fecal formation, so that they can able to predict. So the problems faced by the patient with stoma is skin excoriation. So the skin excoriation is the one of the major problems. Peristomal skin reaction. Always identify the cause. Sometimes it could be chemical, it could be mechanical, it could be microbiological. So whenever the patient complaining comes to you with the complaining of skin excoriation, you have to try to identify the cause, whether there is a chemical cause, mechanical cause, or microbiological cause. So if there is a skin excoriation there, you just if you have a that karaya powder, then you can apply karaya powder for that. And if you don't have a karaya powder, then you can go for a barrier cream, and or you can use zinc oxide powder. So these are the three things you can use for managing peristomal skin reaction. So if you use the karaya powder, you can take powder, karaya powder, and mix with the white portion of the egg and apply on the skin, peristomal skin reaction area. So the skin excoriated area, and wait for 2 to 5 minutes. So after that, you can you can fix a colostomy bag. And the next problem is stomal prolapse. So if the patient is having stomal prolapse there, minimal to 1.5 to 2 centimeters is normal, but more if you have seen more than that, you can try to reduce the manual reduction. You can try, so you can do, but you can lubricate your little finger with the silocaine jelly and try to insert the prolapsed area into the abdomen. And after that, what you can that educate the patient is, when they cough or sneeze, they have to support that area. So otherwise, that area again will come out. And the third one is stomal retraction. So here you can see the stomal retraction. So if there is a stomal retraction there, we are not able to fix the bag properly. So what you can do is, you can use a convex pouch system. So here is this is the convex pouch system. This bag you can use for stomal retraction patient. So coming to the next area is stomal stenosis. It's a narrowing of stoma. If there is a severe stenosis there, the patients will complaining of abdominal cramps. So that needs a surgical correction. So this is a narrowing the stomal stenosis. That fecal matter is not able to come out if there is a stomal stenosis there. If this problem there, better you can refer the patient to the surgeon. And the next one is constipation. Again, the patient, if there is an inactive stoma for 4 hours there, then if the patient is having abdominal cramps, then you can better you can refer the patient to the surgeon. So, or you can use stimulant laxatives. Try on course of 1 or 2 days with the stimulant laxatives, and if the problems persist, but sometimes there is a obstruction there, so that kind of things will be there. If these kind of problems there, then you can refer the patient to the surgeon. So these are the major problems, and sometimes peristomal hernia will be there, and yeah, parastomal hernia. So bleeding will be there. So some losing kind of bleeding will be there. If the bleeding is severe, then you can better you can refer the patient to the surgeon. And some I have seen one patient like a necrosis, stomal necrosis. So that is also another complication. So these are the complications of colostomy. So I think we can watch for the management part, we can watch a video on that, and after that I will discuss. So I hope the procedure is clear to everyone. The next is the colostomy diet. So there are no absolute dietary restriction for these kind of patients, because they can use whatever they want. But the thing is, if they sometimes if they cause order, like if they are using too much cabbage, garlic, beans, these kind of things, that food items may produce odor. If they are complaining of malodor, so this is the major problem here. So then you have to tell them, you please control these kind of they not need to stop all those things. They can control these kind of foods. Then if the patient is complaining of constipation, again, corn, nuts, cabbage, vegetable peeling, so these all things can produce constipation. These things they can control. And if they are complaining of loose stool, again, coffee, fruits, and these kind of things. Because usually what we tell them is they can use, if possible, they can use the same oil for making food and all, so that we can able to prevent diarrhea. And so here, so these are the important points you have to keep it in mind. Okay. So the Henry Cotter tablets is also you can avoid, because there is no role here to act. And travel, work, and sports, so they can travel anywhere, but the thing is they have to protect the stoma, because the other traveler don't know whether the other person is having colostomy or not. So better they can keep a hand purse or anything, and they can keep they can protect their that stoma when they're traveling, and they can carry extra bags. And also so normal works they can do, avoid contact sports like major, so that will again cause injury. So these all things you have to tell the patient. So coming to the next case scenario, anyone please read it out.
A 45-year was diagnosed with carcinoma rectum and had undergone EP resection and segment colostomy 3 months ago. He has been using disposable colostomy bag for bowel emptying. He is a management executive and I find it very difficult to manage it. What option can you advise him as a palliative care doctor or nurse?
Any idea?
Colostomy irrigation.
Okay. Any other opinions?
Maybe carrying, having a bigger bag or
So that is not possible, ma'am, because if they are having a bigger bag, what do you think? Because if the fecal matters is that quantity increase, again the stoma, that wafer will loosen from the stoma, no? So they can use a small bag. So whenever
Frequency of
the
drainage can be changed.
sorry,
Frequency of drainage can be changed.
frequency of
Means before
removing. So
going to work.
that is the major problem here. So he is a management executive and find it's very difficult to manage it. So that is the problem. He has enough money to the buy bags and all. So that is not a problem, because as I mentioned earlier, whenever our bowel is moved, that bowel movements happen, the fecal matter will come out, no? So he needs to change the colostomy bag in between his work, because of that part it was affecting him a lot. So that is why he was come with you, because he's come with his complaint. It's very difficult to manage. Is there any other alternate option?
his food timings we can plan accordingly. Meal timing.
Meal time. Okay.
Hmm.
So here, yeah, so I think as Biju sir said, we can go with the colostomy irrigation. So here, the thing is, this patient is having sigmoid colostomy. As I mentioned earlier, there are 4 parts of large intestine: ascending colon, transverse colon, descending colon, and sigmoid colon. So if you do the sigmoid colostomy, the fecal matter is completely formed. Okay, so if there is a sigmoid colostomy or the end portion of the descending colostomy there, then you can choose colostomy. You can suggest colostomy irrigation. So you can irrigate the colon in the morning, so that after that 6 to 8 hours the colon will be free. Okay, so you can give us colostomy irrigation here. You can suggest colostomy irrigation here. So if they are agree, so if the patient is agree with the colostomy irrigation, then you have to tell the purpose. So these are the purpose of colostomy irrigation. So you can we can establish the regular bowel habit. You can clean the colon gas and mucus and fecal feces, and then if you do like this, we can prevent skin excoriation also, because so at a time we can able to wash out the all fecal matters, and after that the bowel, that area will be free only. Okay, so there is no chance of developing skin excoriation. So these are the purpose of colostomy irrigation. The solution we can use for a colostomy irrigation is plain lukewarm water. And if you give a purpose, if you tell them for a colostomy irrigation purpose and these all things, sometimes they will agree. So if they are agree, you have to give a proper instruction, because what are the instructions? They have to irrigate as a lifelong. They have to. This is very, very important. Otherwise, they might be thinking like, okay, whenever they need, they can irrigate. So these important instructions you have to tell them. They have to do it as a lifelong, and they have to fix it particular time for irrigate. And if they do it, if they follow these 2 instructions, definitely the habit formation will be there for within 21 days. So these are the instructions you have to give to the patient. Okay. And we have a video on that colostomy irrigation. We can watch on this, and then I'll take if you have any question. Okay, thank you. Any doubts?
Colon irrigation should be done only for distal ostomies.
Yes, ma'am. If the patient is having sigmoid colostomy or end portion of the descending colostomy, that area only the formed the stool there. So that time you can instruct the patient about colostomy irrigation. So otherwise, the other part of the intestine, the colostomy area, fecal matter is liquid only.
Okay.
Here is a formed stool. That's why we suggest colostomy irrigation here.
Okay, thank you.
So the next part is tracheostomy. So if in the meantime, if you have any questions, please put it in the chat box so that we can try to answer it and then later. So here is the tracheostomy. So we all know that tracheostomy is an artificial opening made into the trachea. So for the through that area, the tracheostomy tube is inserted. So our aim is to establish a pattern airway. So there are 3 parts: outer tube, inner tube, and obturator. So there are 2 different types of tracheostomy tubes are there: vortex tube and metal tubes. So it has 3 parts: outer tube, inner tube, and obturator. So the outer tube you have to held in place, and you can fix the outer tube. You can fix the outer tube with the help of a tie. So that outer tube you have to held in place all the times. So for the inner tube, you have to take it out from the outer tube and clean under running water and replace back. So you have to educate the patient and caregivers about the same. So with the help of a mirror, the patients can do these procedures for the removing the inner tube from the outer tube and clean under running water, and they can able to replace back. Okay, and the purpose of obturator is guide to the outer tube into the insert into the, while we insert the outer tube into the trachea, so the obturator will be able to guide get the trachea to properly inserting a outer tube into the trachea. So how to keep it in mind, there are three parts: outer tube, inner tube, and obturator. Okay, so if you seen that outer tube, the three parts, outer, you can just look into the inner tube and outer tube. Our inner tube is longer than the outer tube. Okay, little bit longer than the outer tube, because if the inner tube is shorter than the outer tube, what happens? The outer tube will block with the secretions. So that is why the inner tube length is little bit longer than the outer tube. Okay, so as I discussed earlier, you have to train the patient for clearing the inner tube, and they have to, so if they are using metal tube, they have to take the inner tube from the outer tube and clean under running water and boil it, and after that they have to replace it. Because if better if they are using metal tube, that if they are doing a permanent during the initial period, they will give a Portex tube. After 3 months, they will change the Portex tube to the metal tube. So you have to train the patient about how to do the cleaning for that metal tube, and how to give clean the Portex tube. That is little bit different, because Portex tube you should not you don't give up put into boiled water, because that will damage. So for if they are using metal tube, they can boil it. So after that they can soak with the normal saline, and before inserting the tube into the trachea, into the outer tube, so they have to make sure that there is no water inside the that inner tube. That is very, very important. And outer tube also, if they want to change the tie, they have to fix a new tie first and then try to remove the old tie. And skin care is also important here. And suction and humidification, you can here that dry cough is the most common problem here. Better you can take a net clothes or gauze piece and squeeze it. You can soak with the normal saline and squeeze out of excess water and put it on the tracheostomy area, so that the patients will get a humidified air. And also you can use a stoma protector, and you can educate the patient about speech therapy also. They can speak at least 1 or 2 words. So they can take a deep breath and speak 1 or 2 words. So that is also you can educate. And we have a video on that. I think Sripriya will show you now. And any doubts so far? Any doubts? So better you can tell the patient to cover the tracheostomy area with the netted cloth, like a stoma protector or something like that. Otherwise, maggots formation is one of the most common problem here. The patient is having tracheostomy. So
how long can we use this Portex with the cuff?
Which one, sir?
The Portex, the plastic one with the cuff. You showed with the cuff now, which you can inflate.
Yeah. So for the, I think we have seen many patients with that metal tube. If because for the initial period only they will come with the Portex tube. So after that they will change from Portex tube to metal tube. If you do the permanent tracheostomy, definitely the patient will come with the metal tube. that post-operative period, I think we have to deflate the air and inflate the
Yes,
air
ma'am.
in between.
Yes.
So otherwise that
Because
tissue
necrosis.
injury. Yeah.
Necrosis also.
Yeah. Yes. So I think we can move on to the next part. So that is subcutaneous infusion. So I think most of you are knowing what is subcutaneous infusion. So we know there are three major layers: dermis layer, subcutaneous layer, and the muscular layer. So if you do the subcutaneous infusion, you are going to give a fluid into the subcutaneous space, or you are going to give a medications into the subcutaneous space. So from the subcutaneous space, the tissues that will goes to the systemic circulation, because here the diffusion technique. So from the lower concentration to the higher concentration area, the fluid will move. Here the subcutaneous area is the lower concentrated area, but the circulatory the area is in the higher concentrated area. So here the diffusion method, the fluid absorption is happened. So subcutaneous infusion is also known as a hypodermoclysis. Hypodermoclysis is, so you called it, you can give an infusion with, or you can give an isotonic fluid into the subcutaneous for the space for rehydration or preventing dehydration. For if the patient is having mild dehydration there, then you can give subcutaneous infusion and correct the dehydration. But if the patient is having severe dehydration there, you will not, this will not help. So you are going to instead small volume at a time instead of large volume. So this is the subcutaneous space. You at a time we can able to give a small volume. So the common indication is preventing dehydration. Mild to moderate dehydration we can prevent, and severe dysphagia if the patient is not able to swallow properly, and especially head and neck cancers. So that patients, if they are not able to swallow properly, and if they are not able to take the medications orally, then you can give subcutaneous infusion or subcutaneous infusion, that continuous infusion methods, that medications and all. So, and fluid needs less than 3 liters per day. Maximum 3 liters we can give at a time for different that areas. One side we can give 1.5 liter for 24 hours. So if you want to give more than 1.5 liter, you can choose different sites. Coming to the indication in palliative care, nausea and vomiting, severe nausea and vomiting. So mouth, throat, and esophageal lesions like head and neck cancers, intestinal obstruction, unconscious patients, either semi-conscious or unconscious patients, you can use this technique. And intractable symptoms like we are not able to control that symptoms, the refractory symptoms by oral methods. So they are not able to, you are not able to control with the oral medication, then you can choose this method. And rectal route is inappropriate. We know there are the morphine, we can use different routes. Rectally also we can use, but if the patient is having any rectal cancer or any tumor in the rectum, so we can't use that technique, that route, no, rectal route. So that patient also you can choose subcutaneous route. So these are the common sites: upper chest, like intercostal plain area, upper arm, outer aspects of the upper arm, abdomen, outer thigh, upper back, and scapular area. So these are the common sites which we are using for subcutaneous infusion. So these are the areas is not using lymphedema site. If the patient is having lymphedema, you don't choose that area for lymphedema. for subcutaneous infusion. So the skin site that have recently irradiated, so radiation, radiotherapy, if the patient is taking radiotherapy, so that particular area you should not select. And bony prominence, if you select the bony prominence, again the movements will be affected. And in close proximity, the skin folds and inflammation and infections, ascites and pitting edema, tumor. So these are the areas you have to avoid while we choose the subcutaneous infusion sites. So coming to the medication part, most of the medications which we can able to give through subcutaneously, for example, injection morphine, haloperidol, midazolam, metoclopramide, buscopan, fentanyl. So these all medications which we can give through subcutaneously. But so these are the 3 medications we can not give, like Stamitil, diazepam, labdatil. So these medications contains oily preparation. So these medications you should not give. But if you look into that medications part, most of the medications we can give through subcutaneous. So coming to the procedure, so I think we have a video on that. So we will watch on it, and after that I will explain about the few important things. So, okay, thank you. So the next thing is oleum rate. You already seen from the video. 1 ml per minute you can give at a time. So 20 drops. So one site you can give 1.5 liter for 24 hours. If you want to give more than 1.5 liter, you can choose 2 sites for giving a subcutaneous infusion. So the advantages, sir, low cost, more comfortable than IV administration. If you do the IV administration, so sometimes you will not get intravenous line. So you will give a multiple pricks for getting intravenous line. So here, if you choose the subcutaneous infusion, 1 prick is needed here. So that way we can able to reduce the patient the pain, and less likely than IV administration to cause pulmonary edema. So these all things we know. So because there is a absorption is very low, so less chance of pulmonary edema and fluid overload. And a simple insertion, as I mentioned earlier, more suitable for home care settings. You can train the caregivers also. If you put that subcutaneous route and connect a line and tell them to remove the needle, because there is no worry to bleed or something. So the needle is in the that subcutaneous space. That does not cause any thrombophlebitis, and also it will not cause any septicemia or systemic infection, and can be start or stop at any time. Because if you stop in the intravenous line, what happens? So sometimes clot formation will be there, and sometimes that we need to change the site also because of the clot formation. So these all things we can avoid it if you choose this subcutaneous infusion. Okay. And these are the some side effects, because what you have to educate the patient and caregiver is the in and around the site, the little edema is normal, that will subside. Okay, so that is the important instructions you have to educate the caregivers and the patient, because they don't know that subcutaneous infusion. They usually seen with intravenous infusion. If they have developed any edema, so they usually the nurse tell like, oh, they have you have to report me if you have developed any swelling. So here also, if there is any swelling happen, they usually come to you and report you like I have a edema here. So if you choose subcutaneous infusion, you have to tell them so little some edema is normal. And localized edema, that is normal, and so that will subside soon. That kind of information you have to tell them. And for the inflammation, sometimes inflammation and cellulitis can happen, because if you do it an aseptic technique, it will not happen. So that is also one thing you have to keep it in mind. And the pain and discomfort in the at the insertion site, that is very rare. But if you give a fast infusion, so here we are going to give a small volume at a time. If you give a large volume at a time, the patients can develop pain and discomfort also. Okay, that also you have to tell the caregivers. Okay, and if the needle is in the intradermal space, then the patients may feel pain. So that is also another thing. And puncture of blood vessels during insertion, that is also very rare things. If there is any blood you have seen in the tubings, better you have to remove the that needle from that area, and put it give choose another site for subcutaneous infusion. And hematoma around the insertion site is also very rare. So, and the infusion device occlusion is also very rare, because there is no like sometimes it kinking and external tubes, that is the only way to that occlusion. Otherwise, it will not happen. So these are the some side effects you have to keep it in mind. But what you have to, as I mentioned earlier, what you have to tell them is some edema is normal, but that will subside gradually. And the next thing is, if there is any leakage or irritation there, they have to report us. So these are these two instructions you have to tell them. So the advantages is very, very important. These are the advantages you have to keep it in mind. And syringe driver, I don't know how many of you have seen syringe driver. So syringe driver, in Palliative India, we usually use syringe driver for continuous infusions. So this is a small portable battery drive infusion. Like I think many of you have seen a syringe pump. But this is a syringe drive. It's a portable battery machine. They can able to, the movement is not restricted. They can able to move around, and you can use, if you want to give a continuous infusion, you can better you can give it through syringe drive. So I think, any doubts?
Hello.
Yes, ma'am.
Hi, Sheeba. Thanks for such a beautiful presentation, firstly.
Thank you.
Yeah, so I had two questions. One regarding this, that I have used these butterfly, scalp ones long back, but I don't know how commonly it's available. At least in my place, I'm not even finding such devices, So just to know, because we sometimes even use a normal IV cannula and put it in the subcutaneous place at 24 gauge or something like
24,
that.
yeah, yellow.
Yeah, so
That
is it
pediatric
okay to
cannula.
use that? Yeah,
Yes,
pediatric
yes.
cannula.
Yes,
So
you
can we use
that.
that?
Yes.
We can use that, right? And two, suppose if we use a scalp vein, how long can we keep it? Because it's a needle, right? So it can be a little uncomfortable after some.
Maximum
experience?
7 days, 7 days,
7
5 to
days.
7 days. But if they have it, they develop any irritation or any redness, better you can change the site.
Okay. Okay. Thank you so much.
Sunil sir, anything
Shiva
you
madam,
want
what
to add?
about NGT insertion and urinary catheterization?
Sir, Sunil sir.
Those are basic things.
There might be some tricky questions there also, sir.
So
I don't know.
I'm
Sri
going
Priya
to.
might ask.
So, sir,
I am
can I
collecting
do the?
clues from this discussion, sir.
Yeah. Don't give any clues, because she is going to talk to the examiner to set some questions on that.
Sir, I already covered the wound management part, but I would like to highlight few things from that wound management part. So like a recap, so let me. So this is a patient scenario. Mr. M, 60-year-old bedbound patient following a fall from a height 3 months ago. He has lost sensation and motor power below the umbilicus and having sphincter incontinence. He is unmarried and lives with his older sister. Both of them do not have a fixed income. You are a doctor on a home visit and find it that Mr. M is having 3 ulcers on the sacral area, affecting the tissues, not exposing the muscles, and the other 2 bed sores, one on the right heel with loss of skin and the next on the left heel with the black necrotic tissue. So my question is, what are the stages of ulcers mentioned here? We already discussed the wound management part.
Anybody can answer.
That sacral area one is grade 1.
Okay. Any other
And the
answers?
next on left heel with the black necrotic tissue is unstageable.
Okay.
One is stage 2. And I think the one on the right heel, that is also stage 2. And the next one is on the left heel is unstageable.
Okay.
That's what I think.
Okay. We'll come to that. What are the 3 risk factors and 3 preventive strategies in the care of these ulcers? So you have to tell the risk factors from this patient story. There are a lot of risk factors, but from this patient story, what are the risk factors you have identified?
He is bedridden, he has lost sensation, and he's having sphincter incontinence.
Okay. Any other things?
Position change is not frequent.
Sorry, sir.
Position change is not frequent because
Okay.
he's
Yeah.
nobody
So
is there
yeah,
to help.
say immobility. Immobility is one of the major risk factor. So and as Priya said, sphincter incontinence, the moisture is another reason. Then, so the thing is, he is unmarried and lives with his older sister. Both of them do not have a fixed income. So lack of nutrition is another problem here. So lack of protein intake in their diet is the third reason for getting pressure ulcer. So what are the preventive strategies? So if there is a pressure sore there, our aim is to prevent further deterioration. No? So what are the things you have to educate the patient and caregivers for preventing pressure ulcer formation?
Waterbed.
Position change.
Waterbed,
Position change. Very good.
change.
Dressing.
Dressing for prevention. Prevention.
Using waterbed or airbed.
Airbed. Okay, you can suggest airbed or waterbed.
Airbed.
Catheterization.
Okay, if the patient is willing to put a catheter, you can put a catheter. But if they are not willing to put a catheter, you can suggest diaper. So another thing is, if they are not affordable, they can use their own sheets or clothes. But the thing is, if the linen is wet, they have to change it as soon as possible. So that
Explain the importance of keeping the area dry and.
Okay, very good.
Better nutrition.
So better nutrition. So yeah, so And the skin inspection, whenever they turn the patient from one position to another position, they have to inspect the skin and check whether there is any color change or not. So here, pressure ulcer stages you have mentioned. There are 6 stages. The first one is non-blanchable erythema, right? So the first stage is non-blanchable erythema. The second stage is partial thickness, only skin loss. Only skin loss. The first stage is non-blanchable erythema. The second stage is only skin loss. So this is the second stage. But there is no infection. Sometimes blister formation there. If the blister formation there, definitely the skin will break down. So third stage is full thickness ulcer. All tissues will be affecting. The subcutaneous tissues will be affecting. The patient is also affecting the tissues, affecting the pressure sore into the tissues, not exposing the muscles. So if the bed sore is affecting to the muscles, then it goes to stage 4. Stage 4. The fifth one is unstageable. So the one pressure sore is on the heel, that is covering with the black necrotic tissue, that is unstageable. But one is only loss of skin, that is stage 2. Okay. And the sixth one is deep tissue pressure injury. So this kind of things changes will be. We already discussed these things. And management part, you all know that. And coming to the prevention, position change, manage incontinence, special surface like air mattress or water mattress, and nutrition, massage, provide wrinkle-free bed, nail care. So these all things you have to keep it in mind. So I think we can stop here. So one more patient story here, just to highlight one. So here, 65-year-old man diagnosed with the CA right buccal mucosa, living with his family. He came to your OPD for cleaning and dressing. His main complaints were foul smell and exudate. So what could be the possible reason for malodor? How will you manage it?
Fungating mass.
Okay.
Infection.
What is happening? Because here, so because of a lot of necrotic tissues into the fungating ulcer can cause bad malodor. And the another cause is stale exudate dressings have been placed in number of days, can cause malodor. So the management is, you all know that. Also, how will you manage? How will you manage? So metronidazole is, you have to clean the wound with normal saline. You can apply local metronidazole. You can take tab metronidazole and crush it and make it a powder form and apply on the wound. And you can irrigate the wound with injection metronidazole. You can try on course of systemic antibiotics and charcoal pieces. You can keep charcoal. This is the one agent, is a good agent for absorbing bad smell, charcoal. You can keep charcoal pieces under the bed or keep it in the corner of the room. So, or you can choose charcoal dressings. Here, no hydrogen peroxide and betadine. So these are the ways we can manage malodor. The drug of choice of controlling metronidazole, that anaerobic bacterial infection, is metronidazole. Okay. Thank you. Any doubts? Sir?
For maggots, Shiva.
Yes. How does maggots come?
Flies, exposed to flies.
So it comes from house flies. What you have to do is advise the patient to cover the wounds all the time. So, and also you have to tell them how does maggots come. Then only they will cover the wound properly. So if there is a maggots there, or the physical removal is the only way to clear the maggots, or you can use turpentine oil. Soak the turpentine oil with the gauze piece and keep close to the area, so that all maggots will try to come out. So that time you can take it out with the help of artery forceps. Okay, so and the another important things, as I already mentioned earlier, don't follow maggots. When they come out, you can take it out. If you follow maggots, what happen? Your artery forceps will rupture the blood vessels. So we don't know. There are a lot of pocket formation there. They will go inside and keep safe there. So when they after few minutes they will come out. So that time you can take it out. When they go inside, you can leave it. So after that they will come out and you can take it out. Physical removal is the only way to remove maggots, and the proper education of the patient and caregiver is also important.
Okay. So, Sripriya, are there any more questions that you got from the examiners?
No, sir.
Okay, so Sripriya is the spy here.
Sir, I'm
Please,
planning
please share.
to start an organization, sir, with a lot of spice.
Okay.
Sir was asking about the catheterization and nasogastric tube feeding. So catheterization part, you have to understand that different types of catheters are there. Foley's catheter, silicone catheter, clean intermittent, that Nelcat, quantum catheterization, the catheter, these all things are there. So the major difference between the silicone catheter and the Foley's catheter is the silicone catheter is made up of silicone material that is tissue friendly and less chance of infection. That Foley's catheter is made up of latex materials that is easily to develop infection. So that's why we can keep up to 30 days. Every 30 days you have to change the Foley's catheter, but for the silicone catheter up to 3 months you can keep. Every 3 months you have to change it. And it's clean intermittent catheterization is also you have to understand for the paraplegic patients. If the sphincter control is okay, then you can suggest clean and intermittent catheterization. But you during the sleep time, they can use quantum catheterization. Quantum catheter for training.
Madam, in NGT insertion, one thing I wanted to ask, what is the best way to ensure that the tube is in the stomach rather than going to the trachea or bronchus?
So what you have to do is after insertion you have to aspirate the stomach content, gastric contents. That is the only the major important things you have to do.
Yeah, but if the stomach is empty, then how can we be sure that
what we do is we take 10 ml syringe and the fill with the air and push the air into the through the nasogastric tube, and you can listen the sound of the cephisternal area.
Yeah, we do that, but I mean, I'm saying, is that a foolproof mechanism? Because sometimes we can hear the air from the bronchus also. So,
so the confirmation is only radiological.
Yes, sir. This is the problem which we face when we go for NGT.
Yeah, home care. Yeah.
Yeah, but what about litmus test? What about litmus test? I mean, is it reliable?
It's also not reliable. The only thing which the confirmation, they say it's only radiological.
Yeah. What about the air bubbles? I mean, if you put the tube in the
no. Those are things which usually everybody uses, but those are not confirmatory tests.
Not confirmatory,
but what is available in that atmosphere during home care? So that's what we are doing.
That's what we can do. Yes.
Yeah.
So if we try to push in air when it is in a bronchus or it's not placed properly or there is a kink, the syringe will also not move well. There will be a lot of resistance. So whereas if it is in the stomach, it will be very fast, like, you know. The confirmatory is X-ray, but these methods would also like.
Yeah.
If it is in the bronchus and the patient is conscious,
He'll
he
cough.
will
He'll
cough.
cough like
So there
anything.
is no need of looking for resistance for syringe. That comes only if the patient is unconscious and things like that. Otherwise, usually even they will have, if they are comatose, they may not have anything, any reflexes, but otherwise there will be some reflexes.
Yes, sir. Thank you, sir.
Okay. So I hope all of you are learning well and
Too much to study, sir.
no, I think you have to read the materials for foundation course, then the modules which was given for master class, then advanced learning module, that 33 module online, and probably introducing palliative care by Dr. Robert Ricos.
It will take another 6 months to finish.
Just wanted to know, it'll be like you have the first day you'll have a theory exam and next day you'll have MCQs and how was it?
No. So I think I have already given you the sample or the methods by which we are going to evaluate. I think there will be 2 theory papers, each for 1.5 hours. And so first day, there will be 2 theory papers and OSCE. And second day, there would be Viva. There may be some changes, but this is the plan.
Three papers the same day, 1.5 hours each, sir?
Yeah. So from 9 to 12 or something like we would have theory paper, and from 2 to 5 we will have OSCE.
So first day itself will be dead, no, sir. intense questioning.
1.5 hours each theory papers.
Okay. Okay, sir. Thank you.
Cipriya, am I right? Cipriya is the person who is deciding.
We will take care of Sheepriya very well, sir.
Yeah. That you have to.
Sir, I have taken care of my health for 11.5 months now, and now you're going to
Ruin it.
yeah.
Yeah. So when you come for examination, first thing is to meet Sripriya and ask her.
Don't look out for someone in hijab covered in full black cloth. That will not be me.
Do some puja for her, sir. That will be better. Sripriya.
And another thing I want to tell you is whenever there is some OSCE or wherever you have to do procedures, first thing would be you need to introduce yourself to the patient. And if they are in distress, ask them whether would you like any medicines to relieve your pain, or then after we can talk, what would you prefer? So self-introduction would be very important in OSCE. So just giving you some hints. This is okay. Okay.
Thank you, sir.
Yeah. Thank you,
Good
sir.
night.
Good night, sir.
Thank you, sir.
Any more sessions, sir?
I think there will not be, but if you think if Sripriya think she needs to give some clues to you, then she will arrange a session.
Then we are ready for 10 more sessions, sir. If she gives clue.
Sir, you and Sheba sister are making things harder for me. Now I'll have to tell the examiner to avoid all these questions and form new ones.
Okay. Okay.
Thank
Bye.
you.
Good night.
Thank you, everyone. So keep preparing.
Thank you.
Just one more month to go, and we hope that everyone will come out in flying colors. We also look forward to that. Thank you, everyone. Take care. Bye bye.
Thank you.
Thank you.
Bye-bye.
Thank you, Shiba sister.
Thank you.